it's a great pleasure to introduce Dr. Ronald Moore, who is a surgical oncologist, urologist. So he's one of those guys who does that amazing stuff, right, that you were talking about. And he's traveled here actually from Edmonton and works at University Hospital in Edmonton. He's kindly agreed to stop here in Toronto on his way to Florida for a water skiing holiday with his wife. So that sounds pretty fun. Today, Dr. Moore will give us an update on surgical treatments for kidney cancer. So please help us welcome Dr. Moore.
Thank you, Marion. Dave, wow, what a journey. I mean, that is an incredible story. When I was told I was going to follow Dave, I Googled him, so I knew what I would be facing. And it is an incredible story. But consistent with the theme of knowledge and empowerment, I've entitled my talk, Kidney Cancer and Surgery and Living Well. And it's intended for patients, survivors, and their caregivers. And it's going to also present a story and a journey about surgery and about what we know about kidneys. I'd like to acknowledge that I've received support from these foundations for my research and what I do. And when I was asked to give this talk, there we go. Joan gave me some objectives. She says, you're to review surgical treatment of kidney cancer and reinforce nephron-sparing surgery and reinforce the importance of follow-up and avoid using graphic pictures. So I'm going to do that. I have no real disclosures outside of the fact that I do have some biases. I'm a transplant surgeon as well as an oncologist, and I believe in ice preservation of kidneys and preservation of many nephrons as possible. So what is a kidney? A kidney is a paired structure located in the back. It's hidden in behind the bowel, and normally you're born with two of them, and some aren't. Some are born with one, and some are born with two that aren't quite as good as having just one. So not everybody has two good kidneys when they start off. And the most important part in the kidney is these little tufts of blood vessels called the glomerulus. And their function is to filter the blood. And approximately 800 mils of blood per minute go through the kidney, and approximately 120 mils are filtered out per minute. And the kidney's function is to resorb all those salts and to manage waste products in doing so. And it's very energy dependent. So the kidney is a structure that requires a lot of blood, uses a lot of energy, and it's also involved in hormonal factors as well. How durable is a kidney? Well, we all know from the story we heard that we're not going to all last forever. As soon as you're born, you're on a course of dying eventually. And your kidneys aren't durable either. They eventually start to fail, and those little glomeruli start to fail, and the glomerular filtration rate starts to go down. And there's an increase in chronic kidney disease, and that chronic kidney disease starts to peak around between 60 and 70 years in life. And the highest risk of developing chronic kidney disease in your lifetime is posted there. So the chance of reaching end-stage kidney disease where you require dialysis in a person's lifetime is about 4.4%. But there's a large proportion of patients that have stage 3 kidney cancer, so with a GFR of less than 60, by the time they're actually diagnosed with kidney cancer. So what do we know about kidney cancer? So it's the 7th most common cancer. This is sort of like preaching to the choir, right? You guys know about this, but it's more common in men than women. It's the 12th most common cause of cancer death, and it's highly lethal cancer. Not many people survive, like the story we heard, with metastatic cancer. The risk factors for kidney cancer are probably some of the most important things. So smoking, obesity, hypertension, then there's genetics, and then end-stage renal disease itself can cause kidney cancer. I've already told you that there's a higher incidence around the 6th and 7th decade. And over the time frame, there's been a stage migration. And I'm going to tell you what that means. So, epidemiology, or what causes kidney cancer, I've already told you about the main ones, but chronic kidney disease itself causes cancers. So there's a higher incidence of kidney cancers, and there's a higher incidence of other cancers in patients that have chronic kidney disease. What we know about kidney cancer can largely be attributed to the work of Mars and Lanahan and Burton Zabar in studying the molecular genetics of hereditary kidney cancer. And the most common kidney cancer is clear cell renal cell carcinoma, and the second most common is papillary. And these tumors have a molecular basis and an understanding that can be attributed to the studies that were done at NIH. We know clinically that hereditary renal cell cancers are multifocal, and they can occur in the opposite kidney when you're diagnosed, and they're also more likely to occur at a younger age, whereas the sporadic ones tend to be unifocal, and the chance of them actually occurring elsewhere in the kidney and in the contralateral kidney is only about 5%. We also know, based on the work of NIH, that through these signaling pathways and what goes on in the kidney is that there's growth factors that drive blood vessel growth, there's growth factors that drive the utilization of energy and glucose metabolism, and then there's other growth factors that just cause the cells to grow. And these molecules that we now understand can be targeted with small molecule inhibitors that some people are on. And as well, they can be targeted with antibodies, so the immune system specifically designed to attack these molecules that tell the cancer to grow. So staging, we already heard from e-patient Dave about staging, and he showed his CAT scans. So staging just basically means how much and where it is. And patients need to know that in planning it, and so do doctors. And we all have to talk in the same language. As we medical oncologists, nursing, everybody wants to know where you're at, and so do patients. So the staging system that we use is an international staging system of TNM. And T stands for tumor, N for lymph nodes, and M for distant metastatic disease. And the higher the number, usually the bigger or more aggressive it is, and subcategories within that. So an early stage kidney cancer, a T1A, is a small tumor that's under 4 centimeters, and a T2 tumor would be something greater than 7 centimeters. And then there's the ones that start to invade into the fat, into surrounding structures, or else they can even grow up the blood vessels, and we have a different stage for them. So this is the classic pictures, and you've already seen it. This is a CT scan and a Doppler ultrasound. And this shows the small tumor inside the kidney. And these technologies really weren't around until the 80s. So in the 70s, incidental cancers or early cancers were only 10% of the time. But with the advent of more imaging and studies, then we began detecting cancers a lot earlier. And you can see for the early stage 1 tumor, there's an increased incidence, and there's a decreased incidence in stage 4 cancers or advanced disease as a result of the imaging. So what are the prognostic factors that we get from preclinical staging and imaging that we do? Well, we want to know about grade, and grade really is how aggressive that tumor looks under the microscope. And grade plays probably the largest factor. If you look at risk factors or hazard ratios, a high grade relative to a low grade has a 5.1 chance of causing more adverse outcome. The stage of the tumor, so what I told you before, where it is, how much there is, has a role to play anywhere from a risk of 2.8 to 5.1. But size, even when you get up to a size of 9, really doesn't have a huge risk factor associated with it. Although as with increasing size, there's actually an increasing number of higher grade cancers. And then there's also the comorbidity. So how healthy the patient is really comes into influence how well that patient's going to do with either surgery, chemotherapy, or any management. So if we look at basically stage and grade of the tumor, we see that there's a correlation with increasing grade of the tumor, and high stage, there's no doubt that there's a poorer outcome. But if we look at size, in all categories of overall survival, cancer-specific survival, and recurrence-free survival, the hazard ratio is quite low. So how does surgery come in and play with what we know about this cancer and what's happened in surgery? Well, the first nephrectomy was performed in 1869. It had a 50% mortality rate at that time, mostly due to sepsis. The first partial nephrectomy, where only a portion of the kidney was removed, was followed shortly thereafter. And then in the 20th century, there was improvement with anesthetics, there was improvement with techniques and asepsis. And at that time, the risk of surgery started falling and became lower. But even in 1937, it was felt that a partial nephrectomy shouldn't be carried out if there was a normal contralateral kidney. Vermeulen actually was one of the first to advocate for nephron-sparing surgery for malignancy. And he says there are certain instances when, for a patient's well-being, it is unwise to do a nephrectomy, even in the presence of malignant growth involving the kidney. So in the 50s, Gordie Howe was with Detroit, and they were winning the cup in those days, right? So we're back in the hockey playoff season. So it wasn't that long ago. In the 50s and 60s, Kerr and Klotz here in Toronto were studying hypothermia for preservation of kidneys. But it was really Charles Robson here in Toronto that set the standard for how kidneys should be treated. And it was radical surgery, cutting out all the tissue, all the kidney, all around it. And the reason for that was the massive size of these tumors at that time. And here's this big tumor involving it, and they were discovered late. We didn't have the imaging modalities we talked about, and so you didn't present until you were quite unwell and had signs or symptoms of the disease. And this is basically, sorry Joan, there's one picture here of a kidney being removed. It is a surgical talk. In the 70s, when imaging started to come in and tumors were found earlier, then they began again exploring partial nephrectomy. And it was really Dr. Andrew Novak and Laura, whoops, sorry, I got to go back. And Laura Woods is here, but Andy Novak really pioneered this and was a real advocate for nephron-sparing surgery and renal vascular surgery and transplantation. And it was Dr. Novak that pointed out in 214 cases that there was only 2 recurrences and the survival was over 95%. And this was followed by other groups, Dr. Herr's group, and basically the operation was very simple. You cut out the tumor, you repaired the kidney, but you had to occlude it to do that, and you packed the kidney in ice to preserve the function because it's a high energy requiring structure. So it set a new standard, the open partial nephrectomy. And this is basically another surgical picture, and I've limited the gore, but here's the tumor, and this is a retractor inside a wound on a flank. The kidney's packed in ice. After occluding the blood vessels, the tumor is cut out and then repaired, just as I showed you in the schematics. Then the urologists began turning their cystoscopes on kidney surgery. And that changed the whole era in what happened surgically. So Dr. Clayman in 1991 did the first radical nephrectomy of the scope, and they stick all these little needle sort of ports in. They still have to get the tumor out, and some ground it out, and some take it out through a separate incision. But by 1992, the first partial laparoscopic nephrectomy was carried out. But not all partial nephrectomies are equal, as pointed out by Dr. Bob Uzo at Fox Chase, who actually trained with Andy Novak at the Cleveland Clinic. And depending on the location of where the tumor is, if it's just on the outside, it's a chip shot, as I referred to last night. You can easily knock it off the kidney without much difficulty. But as they get more central and bigger, and involving along the collecting system, which collects the urine to take it down to the bladder, then there's more potential problems with it. So in common surgery, the risk of dying from the surgery is very low. It's less than 1%. But the later complications are related to delayed bleeding and urine leaks. And the more difficult it is to take it out, there's problems with delayed bleeding, fistulas, and urine leaks. So, whoops, I went too far, or I'm missing one. So if we look at what's going on as a snapshot in 2006, and this was by Holenbeck and another study by Miller et al., we see that in the SEER database for kidney tumors under 7 centimeters in size, only 9% were getting a partial nephrectomy. And nationwide, again, only 9% of all kidney cancers were treated with partial nephrectomy, despite this data and information being known in academic centers. Dr. Gill, who also worked at the Cleveland Clinic alongside Dr. Novick and was very skilled at laparoscopic surgery, and Dr. Novick put out this paper. And laparoscopic surgery still wasn't quite matching up to open surgery as far as repeat operations, operative complications related to it. But patients were getting out of the hospital earlier, and there was difficulty in cooling the kidneys to actually maintain and delay function. But most of that's been addressed with the rapidity at which operations are done. So, where are we today? Enter the robot. 3D visualization, and this big machine has now entered the realm of helping out surgeons do surgery. And again, Joan, these aren't gross pictures. I'm just going to show you that there's this big robot. They put a bunch of holes in you, and then the surgeon sits at the console and sticks all these things inside you that are controlled by a machine with no touch, and they still clamp the artery, and then they take out the tumor, and they put it in the baggie that you heard Dave talk about, and then they take it out. But again, there's still a limitation in not being able to cool the kidney. Dr. Gill, however, is an innovator. You have to realize this guy. He could sell you anything, okay? But he's also very innovative, and so he talks about zero ischemic partial nephrectomy. And these are his latest papers from 2012, where they're not clamping the kidney, but they're doing a radial dissection. So normally when we do a partial nephrectomy, we start outside and work in. Dr. Gill is now working from inside out, following the blood vessels under magnification. It's an interesting operation, but he doesn't clamp the kidney in order to do it. So the blood flow is still going to the kidney. So why all this effort? Why are we trying to preserve the kidney? And I think the data comes out of Memorial Sloan Kettering. The first real paper that I know about was by Paul Russo, who published the results of partial nephrectomy versus radical nephrectomy. And you can see that for small lesions of the kidney, people that had a partial nephrectomy are actually doing better than people that had a total nephrectomy. And the risk factor really associated here was underlying kidney disease. And this was based on earlier work by Dr. Gao out of the Kaiser Permanente. And what Dr. Gao basically showed is that people with chronic kidney disease of various grades actually have a higher incidence of cardiovascular events. So here's the cardiovascular event, risk of death, and hospitalization as your GFR, and I told you what those little glomeruli are, and what they do, and they filter. So as your filtration rate starts to go down, so that you're at stage 3 kidney cancer, or stage 3 renal failure or chronic kidney disease, you start to get an increase in death and cardiovascular events and hospitalization till you're at the level, less than 15, stage 5 kidney disease, where you're looking at a transplantation. So what are the risks of end-stage renal disease in the population? And so we have here, diabetes is very prevalent, and 1 in 300 diabetic patients will develop end-stage renal disease. People with hypertension, 75% of people over the age of 70 have hypertension, or 60, even 60%. So hypertension, 1 in 2,000. Hematuria, which is a sign of having kidney disease, 1 in 4,000. And then even having a kidney stone has an influence on potentially developing end-stage renal disease and what you're born with to start off with. So we even looked at our own data in Alberta, and we looked at what influenced problems with risks associated with nephrectomy. And one thing that stood out is how healthy you are, and then that's shown here. So there's a hazard ratio of 1.3 if you're unhealthy, But also if you've had a radical nephrectomy versus a partial nephrectomy has a hazard ratio of 2, and then early signs of medical renal disease with associated proteinuria. We even went a little further because you can't always believe what you read in the paper and you want to look at your own data to know what's going on. So we looked at a small number of our own patients that had radical nephrectomy or partial nephrectomy, and I had a resident do this. So this is the partial nephrectomy. There was 90 in that group, and radical nephrectomy was 30. But the change in GFR between the two groups is here, so 33 mils per minute versus 16 mils per minute. But the most interesting part of this is that the number of patients that develop grade 3 chronic kidney disease, so going to a GFR of less than 60. So 3/4 of the patients had GFRs less than 60 versus only 1/4 in the other group. So we looked at this further in the literature and what goes on, and I already told you that the kidneys are slowly losing their ability to function. But when you take out a piece of that kidney, you already lower it down further. And then when you put more stress on the kidney with all the treatments that subsequently come, hypertension and everything else, you may accelerate the loss of the remaining renal function that can influence overall survival in the end. So, what is the risk of end-stage renal disease? So some people even have to have their kidneys all removed and then face dialysis and potential transplantation. So the risk of being on end-stage renal disease requiring dialysis is that approximately 10 to 15% of patients die per year on dialysis. That's all comers. That's not healthy. That's not the sickest. That's all comers. So that leads people to advocate, and again, I'm pulling this up from the Cleveland Clinic, so group, and this is Dr. Gill and Dr. Stephen Campbell, looking at their data, to advocate not doing anything for early kidney cancer in patients greater than 75 years of age, because that in itself may have a negative impact. So if we look at the natural history of observed renal masses, in this group again by Rob Uzo at Fox Chase, there's a very slow growth rate of these small renal masses over time. And this is probably best exemplified by the work of Dr. Michael Jewett right here in Toronto when he plots it out. And you can see that all these tumors have different growth rates when he tracked them on a piece of paper. But what's shown here in red is the average growth rate of small renal masses. And you can see the time way out to 120 months. So not all of these tumors grow rapidly. In fact, 75% grow very slowly. So what are the other treatments that are available? There's radiofrequency ablation for small renal masses. There's cryotherapy. The problem with these small renal masses treated with these treatments is that we don't have the pathology on them as to how complete the resection was. We can have a fine needle biopsy up front and then following them along. And there is complications with fistula and other complications sticking probes in. But if we look at what we've came to a consensus with at the Canadian Kidney Cancer Forum, is that certainly for early stage kidney cancers, so stage 1, all should be treated with a partial nephrectomy if technically feasible, and proablation therapy is not recommended for lesions greater than 4 centimeters in diameter. So what about advanced disease? Because the stuff in the middle is all there, but advanced disease, we still go to great lengths to get kidney tumors out, and these tumors have propensity to grow up through the blood vessels, and they can grow up to the heart. And we can take all these tumors out by modern technical advances in surgery. It looks something like this. Again, sorry for the picture, Joan. But we can remove all these tumors and the thrombus, and there's still a survival rate of over 45 to 47%, even before the era of TKIs. And then there's the TKIs, and these compounds, and I'm not going to speak much further about them because there's other people that are going to talk about it, but again, they can inhibit the signaling pathways. There's the mTOR inhibitors that inhibit these signaling pathways for growth, and they have a profound effect. But there's still a role for palliative nephrectomy, which means even if we're not going to cure this cancer and things aren't going well, you still need to have the primary tumor removed, even in the TKI era, to gain further survival. So getting to follow-up of renal masses, because Joan wanted me to talk about that, the more advanced your tumor, the more important it is for follow-up. And certainly for the earlier tumors, the CUA, the Canadian Urological Association, has recommended these sort of follow-up schedule. But with advanced tumors, it's much more closely followed up. But I would like to highlight by a case presentation why follow-up is necessary. This is a 52-year-old male who presented with hematuria. He had a very advanced tumor on his right side, and you can see that it's growing up into the inferior vena cava, up to the top of his liver here. He underwent a big operation to remove this tumor. You can see it sitting here inside the inferior vena cava. And here's the tumor and the tumor thrombus that's growing out. He was discharged with follow-up instructions specific to follow up with his family doctor. And he doesn't follow up. And he shows back up later on, and he's got more tumor. He now has tumor in the left peri-aortic region, so we cleaned out all this side. And he's got a new tumor in his kidney. And he undergoes treatment with the TKIs, and these areas shrink down, and they melt away, or get smaller, where he can undergo basically a follow-up lymph node removal and metastasectomy, and he continues to do well. So the important thing here is that he needed to follow up in order to be found to have other treatment, and his kidneys also need to be followed and monitored by the nephrologist, and Dr. Schmorley is going to talk more about that. So that's the story about surgery and what's evolved, but it's also a story about what's evolved with what we know about kidneys. And you need to have good kidneys, and the more nephrons you have, the better. And you need to follow up, because we do have these newer drugs that Dave talked about, and they affect the kidney. And if you don't follow up and don't participate in trials, then you will not get the newer treatments to help out in caring for your kidney. So, thank you.
Thank you very much, Dr. Moore, for that information on surgical updates for treatment of kidney cancer.